Dear students, Assalamu alaikum. In the last lecture, we learned that hemostasis, which means prevention of blood loss, is achieved by different mechanisms, including vascular constriction, formation of a platelet plug, and formation of a blood clot as a result of blood coagulation. In today's lecture, we shall study clot retraction, the fibrinolytic system, and intravascular anticoagulants. Clot retraction. Within a few minutes after a clot is formed, it begins to contract and expresses most of the fluid from the clot within 20 to 60 minutes. This clot retraction is important because it pulls the edges of the injured vessel for healing. The fluid expressed is called serum. All its fibrinogen and other clotting factors have been removed. In this way, serum differs from plasma. Serum cannot clot. Fibrin stabilizing factor causes more and more cross linkages between adjacent fibrin fibers. Platelets also contribute directly to clot retraction by activating platelet thrombostenin, actin, and myosin molecules, which are all contractile proteins in the platelets. This contractile action of platelets helps compress the fibrin meshwork into a smaller mass. Once a blood clot has started to develop, it initiates a positive feedback to promote more clotting. An important cause of this clot promotion is the proteolytic action of thrombin, which allows it to act on many of the other blood clotting factors. Once a critical amount of thrombin is formed, a positive feedback develops that causes more and more blood clotting. Now let's review the role of thrombin in blood coagulation. Thrombin performs many roles, like number 1, conversion of fibrinogen to fibrin, activation of fibrin stabilizing factor, positive feedback activation of prothrombin, factor 5 and factor 8, and stimulation of platelet aggregation. Let us summarize the role of liver in blood coagulation. Several factors needed for blood coagulation are formed in the liver. These include factor 2, factor 7, factor 9, and factor 10. Formation of these factors is dependent upon the presence of vitamin K, which is necessary for the production of an integral part of these factors. A deficiency of vitamin K may, therefore, produce a tendency to bleeding. Similarly, if the liver is diseased, it cannot make these factors at a normal rate. and will lead to bleeding tendency. In this case, even the administration of vitamin K will fail to exert a beneficial effect. Other factors synthesized in the liver but independent of vitamin K are fibrinogen, factor V, and factor 13. The liver has some other functions also in blood coagulation. These include absorption and metabolism of vitamin K, production of coagulation inhibitors, and clearance of activated coagulation proteins. A clot once formed is not a permanent solution to vessel injury. It is just a transient step to stop bleeding until the vessel can be repaired. If clots are not removed, the blood vessels, especially the smaller ones, will become blocked by clots. In this section, we will study about the fibrinolytic system, which deals with the dissolution of the clot. The clot is slowly dissolved by a fibrinolytic enzyme called plasmin. Plasmin is also known as fibrinolysin. It is derived from plasminogen, and it acts on fibrinogen and fibrin and breaks them down into smaller soluble peptides. These peptides are called fibrin degradation products or FDPs. The FDPs oppose hemostasis. In other words, they promote bleeding. The actions of FDPs are they inhibit binding of fibrinogen to platelets, aggregation of platelets, and thrombin formation. In addition, they also prevent fibrin polymerization. Now let's study the formation of plasmin from plasminogen. Normally, plasmin occurs in blood plasma as its inactive precursor called plasminogen. Plasminogen is a plasma protein having a heavy and a light chain. The conversion of plasminogen to plasmin involves cleavage of the peptide linkage between these chains. However, one disulfide bridge keeps the two polypeptide components bound to each other, forming plasmin. This reaction is catalyzed by enzymes called activators of plasminogen. The activators of plasminogen include the following enzymes: tissue type plasminogen activator, urokinase type plasminogen activator, pro-urokinase, and streptokinase. Let's study the tissue type plasminogen activator. Tissue type plasminogen activator is released from the endothelial cells. It is said to be fibrin specific because it can activate only that plasminogen which is bound to fibrin. The plasmin generated in the fibrin clots dissolves these clots to give rise to the soluble FDPs. At present, TPA is being manufactured by recombinant DNA technology, and the product is called RTPA. Urokinase type plasminogen activator. This plasminogen activator was first isolated from urine but is now known to be produced by many other cells such as monocytes, macrophages, and fibroblasts. Urokinase is not fibrin specific, and it can activate free plasminogen present in blood plasma. It can be manufactured by recombinant DNA technology. Other probable roles of urokinase are to keep the patency of renal, milk, tear, and semen ducts and tubules by preventing the deposition of fibrin within them. Streptokinase. Streptokinase is produced by bacteria called Streptococci. It possesses enzyme activity only when it makes a complex with circulating plasminogen. For clinical use, an acylated Streptokinase plasminogen complex has been produced and is more effective than streptokinase alone. This drug can directly convert plasminogen to plasmin. Now let's study the clinical uses of these agents. Thrombolytic drugs. The plasminogen activators RTPA, urokinase, and streptokinase are used as thrombolytic drugs, which can dissolve clots in blood vessels in emergencies like acute coronary occlusion and pulmonary embolism. If administered at an early stage of vascular occlusion, these drugs can significantly decrease mortality. Antifibrinolytic drugs. These include epsilon aminocaproic acid and tranexamic acid. These drugs are used to treat certain bleeding disorders as well as to control bleeding during major surgical operations. Now let us study anticoagulants. The anticoagulants can be grouped into intravascular anticoagulants and clinical anticoagulants. Intravascular anticoagulants. Endothelial surface factors. The most important factors for preventing clotting in the normal blood vessels are: number 1, smoothness of the endothelial cell surface. This prevents contact activation of the intrinsic clotting system. Number 2, a layer of glycocalyx on the endothelium which repels clotting factors and platelets. Number 3. Thrombomodulin, a protein associated with endothelial cell membrane, binds thrombin. This slows down the clotting process. Thrombomodulin thrombin complex also activates protein C that inactivates factor 5 and factor 8. Another factor which plays an anticoagulant role in the blood vessels is the antithrombin action of fibrin fibers and antithrombin 3. Now, when a clot is forming, most of the thrombin becomes adsorbed to the fibrin fibers. This adsorption prevents excessive spread of the clot. The thrombin that does not adsorb to the fibrin fibers combines with antithrombin 3, which blocks the effects of the thrombin and also inactivates it. Heparin. Heparin is another powerful anticoagulant. By itself, it has little or no anticoagulant properties. But when it combines with antithrombin 3, it increases the effectiveness of antithrombin 3. Heparin antithrombin 3 complex also removes activated factors 12, 11, 10, and 9. Another important point about heparin is that it is produced by mast cells located in the pericapillary connective tissues throughout the body. This helps to prevent growth of clots, especially in the lung capillaries. Otherwise, they would form emboli. The role of plasmin. We have already discussed the formation of plasmin and how it is activated from plasminogen to form plasmin, and how it causes the lysis of clots in the earlier part of this lecture. This figure shows the summary of what we have learned so far. The top part shows the exposure of collagen and release of tissue factor following a vascular injury. In the middle, we see the vasoconstriction, platelet aggregation, and platelet plug formation, and the coagulation cascades, which are controlled by various antithrombotic mechanisms. The lower part of the figure shows the formation of a blood clot and its dissolution by plasmin through the fibrinolytic system. This concludes our today's topic.